Hello and welcome to another episode of Cracking Addiction with Thileepan Naren and Ferghal Armstrong. In the episode of Cracking Addiction today, we're going to start on the first of a few episode arc on some of the comorbidities associated particularly with opioid use disorder. And in particular, for the episode today, we're going to be talking about some of the psychiatric comorbidities for people with opioid use disorders in particular, but also I guess you could generalize this to substance use disorders in general. So Ferghal, I guess an easy question off the bat, why do people with mental illness use drugs?
Well, I suppose, first of all, drugs are fun. But secondly, I think a lot of people, if not the majority of people who use drugs, use drugs as a tool to escape from some form of psychological pain. So coping and self-medicating, I think, has got to be the most salient reason why drug use is so prevalent. And that alludes to the importance of relapse prevention work.
Absolutely. And I should probably preface my earlier question, which should have been, why do some people with mental illness use drugs? Not everyone with mental illness will use drugs. But absolutely, I think you mentioned coping and self-medicating and boredom sometimes and to feel good. And I guess there's also sometimes other factors as well, which is sometimes to counter sexual dysfunction. We know that some of the medications that we use to treat depression, for example, SSRIs and SNRIs, can cause some sexual dysfunction. So sometimes I've certainly seen some patients use some medications or some drugs to counter some of the side effects of their psychotropic medications as well. And I guess also we've got the common issues, I guess, with addiction and mental health disorders and the psycho-biosocial model that we've discussed in previous episodes as well with regards to that. So
yeah, there may also be a common neurobiological underpinning. And this, I think, is, everyone's talked about it in the past, but I think there's actually quite a lot of emerging evidence connecting inflammation, chronic low-grade inflammation, otherwise known as meta-inflammation, connecting that between mental health and substance use disorders. But yeah, there may be, and of course there may be other biological reasons why people have such a susceptibility. It's an interesting concept to explore because, what are the pathways to comorbidity? How do you actually end up having two diagnoses at the same time? Would you care to comment on that?
So it's a fascinating area, and it's one of those which is somewhat complicated and partially understood, but one could view this as mental illness and addiction as separate but contemporaneous conditions. So say, for example, your substance use could be part of your mental health condition. So for example, if you have obsessive compulsive disorder and compulsively want to smoke, there could be a link there. One could think of mental illness as being a risk factor for addiction. We do know that, say, people with high anxiety levels will try and do things to alleviate that anxiety, and that could make one more at risk of using sedative medications such as benzodiazepines as well. And also there's a potential for some addictions or dependences to be a risk factor for mental health illnesses or mental health conditions, such as, I guess, the association between, say, cannabis use and schizophrenia. And we also know that there are some substances which can cause transient mental illnesses or changes in consciousness, such as methamphetamine causing drug-induced psychosis. So I guess those are briefly some of the pathways towards the comorbidity that you were talking about, Ferghal. Would you agree with those statements?
Yeah, I would, and it just illustrates the point that there are many ways in which substance use and mental ill health can intertwine, and it also, I suppose, speaks to the significant co-prevalence, which we will get onto in later on in this subject.
Absolutely. Now, I guess the commonest psychiatric disorders are, in general, the mood disorders. And when we're talking about, say, depression, for example, is there anything in depression that might predispose or put someone at risk of a substance use disorder, Ferghal?
Depression causes psychosocial dysfunction, and that also predisposes to an increased risk of relapse from opioid use disorder. Depression also causes or is associated with high degrees of smoking. So, for instance, and again, this goes back to the meta-inflammation theory. If you measure patients with depression, they've got elevations in their highly selective CRP. And smoking also has elevations in their causes elevations in their highly selective CRP. The other way that mood disorders and depression can interact with alcohol, with substance use disorder, is with alcohol. So we know that chronic drug use causes a depressed mood, and we know that people use alcohol in some way to alleviate that depressed mood, certainly in the short term. But then, of course, in the long term, we also know that alcohol contributes to worsening depression.
Absolutely.
There are other drugs, of course, that can also cause a worsening of mood. What about those, Thileepan?
So, absolutely. So basically, a lot of drugs that can worsen moods due to the effects of the drug. So say, for example, we know withdrawal from substances can cause depressed moods. So basically withdrawing of stimulants or even withdrawing of sedative medications and going through that withdrawal cycle can certainly affect mood and worsen mood as well.
Yeah.
And it can also worsen anxiety kind of going through withdrawal as well. So anxiety symptoms can also be a feature of both intoxication, but it can also be a feature of the withdrawal of substances as well.
Yeah. I mean, going back to smoking, I like to think of smoking as, or dependence on smoking, basically as a chronic dysphoria interspersed with episodic intoxication with nicotine. And so to me, that perfectly illustrates the correlationship between mood and substance use.
Absolutely. Something I get asked a lot about, especially with substance use disorder, is psychosis. And there's a lot of concern about substances that can cause psychosis in our patients. Could you talk a bit more about, in particular, which drugs can place one at risk of psychosis and what the process involves when someone gets a drug-induced psychosis?
So I suppose firstly we need to define what drug-induced psychosis is. And so basically, I am paraphrasing the DSM-5, but basically it's a new onset psychosis characterized by delusions or hallucinations in some form of contemporaneous association with a drug use that is capable of causing that psychosis, therefore causing impairment and dysfunction and distress, whilst also excluding other causes of psychiatric illness. So basically, it's new onset hallucinations, delusions because of exposure or withdrawal associated with a drug that is capable of doing that or making that presentation. So what drugs then? It then begs the question: what drugs do actually cause drug-induced psychosis? So we know that the prototypical drug are the stimulants. So methamphetamine. It is a prototypical cause of drug-induced psychosis. But also we know that cocaine can cause it. We know that cannabis can cause it. We know that club drugs can cause it. We know these synthetic cannabinoids that can cause it. And we also know that withdrawal from hypnosedatives can cause a delirium that can look like a psychosis. But yeah, so it is a recognized psychiatric illness in conjunction with substance use. And that's a kind of a layman's definition.
Excellent. And that's a pretty good marker around psychosis and drug-induced psychosis there, Ferghal. Another question I think that's topical in the here and now is that of ADHD. And ADHD and methamphetamine use are two kind of questions I get asked a lot about. Does having a diagnosis of ADHD potentially predispose someone to being at higher risk of developing a substance use disorder? And I guess something that we get asked a lot is this person who's using methamphetamine someone who has ADHD who's trying to self-medicate? What are your answers to these two quite controversial topics, Ferghal?
Right. It's a it's a very complex subject, right? Does ADHD predispose you to substance use disorder? I think when you look at the impulsivity element associated with ADHD, you are more likely to be impulsive. Therefore, you're more likely to experiment. Therefore, you're more likely to use drugs. Therefore, you are more likely to be exposed to drugs. Therefore, yes, you're more likely to become drug dependent than anyone without ADHD. But it's not an automatic linear progression from having a diagnosis of ADHD to being to having a diagnosis of substance use disorder with, say, stimulant use disorder. It's not an automatic thing. The other question is we need to bear in mind that being on treatment with stimulants for ADHD doesn't necessarily increase the risk of substance use disorder with stimulants. But as your second question alluded to, does stimulant use disorder actually reflect an undiagnosed ADHD and a patient's desire to self-medicate for ADHD? Well, I would say this. For those people who do have ADHD and who do find themselves using illicit stimulants, well, then yes, it does. They are self-medicating a disease. However, if you look at entirely a cohort of patients with stimulant use disorder, they don't all have ADHD. A minority of them will have ADHD. The rest of them will just use stimulants because they feel great. So how do you distinguish the difference between someone who's got a valid diagnosis of ADHD from someone who is using stimulants? I mean, we all know that stimulants improve function in someone who's got ADHD. It improves concentration in particular in someone who's got ADHD. But if you give anyone a stimulant, they will feel as if their function is improving and they will feel as if their concentration is improving, especially when we're talking about doing repetitive, monotonous, boring tasks. There is a reward for using stimulants. They do improve task function on low cognitive demand activities. The problem is that if you keep using them, you end up with the side effects, the long-term sequelae, which include drug-induced psychosis, which includes the vascular complications, the strokes, the heart attacks, things like that, and and also the psychosocial dysfunction. So there is a short-term payoff. So you cannot use the idea, I feel better and I work harder when I take stimulants, therefore I must have ADHD, therefore I am self-medicating an undiagnosed ADHD, and that's how I justify my stimulant use. You cannot use that as a way of diagnosing ADHD. The way to diagnose adult ADHD is to look for the key features of ADHD. So what is ADHD? It is a neurodevelopmental disorder that starts in childhood. So you need to have a good history of childhood onset, pervasive, multi-domain psychosocial dysfunction.
Absolutely.
And really, unless you have that, you cannot say to someone, you've got ADHD as an adult and therefore you need stimulants. The other thing to say is that the stimulants that people use when they've got stimulant use disorder are very, very quick acting. So methamphetamine's got a very rapid onset of action. The stimulants that are used for the management of ADHD have a very slow onset of action. And that's deliberately so. So we know that the speed of onset of action for stimulants will determine whether or not it becomes misused.
Absolutely. Something that often goes along with substance use disorders, or something that we notice a lot of, is sometimes comorbid personality disorders, in particular borderline personality disorder and potentially antisocial personality disorder, which are two of the more common personality disorder types that do seem to have a preponderance with substance use disorder. Does the substance use disorder worsen the prognosis of those personality disorders by and of themselves?
Absolutely. in particular with borderline personality disorder. The prognosis for dual diagnosis, if you've got a borderline personality disorder and a substance use disorder, the prognosis is worse than having cancer. And just think on a societal level, think how many billions of dollars are put into cancer research and supporting people with cancer. Well, actually, there's another diagnosis. There's another group of people who have got a worse prognosis. But unfortunately, this group of individuals are stigmatized and ostracized by society. Those with borderline personality disorder and substance use disorder. So I'm not quite so sure about the figures for antisocial personality disorder, but I'm assuming they're roughly the same cohort. But yeah, the dual diagnosis in personality disorders is so damaging. Absolutely.
Something that those of us who work with people with substance use disorder have noticed or do notice amongst our patients is the significant trauma and harms that have occurred to a lot of our patients, often during childhood, but sometimes throughout the gamut of life. And sometimes there's trauma, then re-trauma, re-triggering. And it seems like a large amount of patients that I've seen would definitely meet the criteria or the DSM-5 criteria for PTSD. Have you noticed this amongst the patients that you treat as well, Ferghal?
Yeah, definitely. Again, it goes back to why do we use drugs? What's the first reason that we said people use drugs? Is to escape pain. So PTSD is a form of psychic pain. And there is a well-documented association between PTSD and the use of drugs. And so, for instance, there's evidence from the Iraq Wars, where 1 in 5 U.S. veterans from the Iraq Wars were diagnosed, who had a diagnosis of PTSD, also had a co-occurring substance use disorder. The other thing is not that I look after, veterans from the American or the Australian involvement in Iraq, but I do look after a lot of women who have been the victims of assaults, rape, child abuse on the part of men. So women who have been victimized women are a significant group of individuals who are at risk of developing PTSD and therefore substance use disorder. And this leads me on to the point that actually one of the core features of PTSD is the fact that there needs to be an exposure to a trauma, potentially life-threatening trauma. Now, the incidence of onset of PTSD is lower. It's less than 10% if you're exposed to a natural disaster, whereas it's higher, i.e. more than 50% of patients who are exposed to a man-made trauma will then go on to develop it. So these traumas that I've just described, abuse, rape, sexual assault, these are all traumas that are perpetrated by one human being on another human being, and they are much more associated with the onset of PTSD, and I think also much more associated with the onset of substance use disorder. So it's just an interesting point to consider what was the trauma, because in my clinical practice, I don't see that many people who are traumatized as a result of bushfires or natural disasters who then have comorbid substance use disorder. I don't see those people. All I see are people who are wounded by other human beings.
That's a very fair point, Ferghal. And you've mentioned dual diagnosis a couple of times in this episode. And dual diagnosis is when you have a co-occurring mental health diagnosis and a substance use disorder. And we know that in general, people with mental illness experience more complications from their drug use than the general population. Does a dual diagnosis complicate the prognosis and treatment of each diagnosis?
Absolutely. Which is, in the case of dual diagnosis, it's really important to get dual treatment, because dual treatment does improve outcome. But unfortunately, the prognosis is actually lower than for anyone with a single diagnosis, because the two diagnoses interfere with each other's treatment. So one of the biggest or the most easiest examples of this is that if you've got a mental health disorder and you've got a substance use disorder, you're less likely to actually attend your appointments because your life is so chaotic. So actually, a lack of attendance to medical appointments can actually be a sign of worsening illness, certainly in the substance use disorder. So engagement is key, and we've spoken in other episodes about just how important engagement is it is the sine qua non of a successful treatment outcome. And really, it behooves us all to ask ourselves, what can we do to improve engagement? Engage.
Absolutely. And coming back to, say, some of the treatments or medications that one might use in the dual diagnosis space, are there some interactions or concerns that we need to be aware of about particular medication types or medications that we need to be cautious around when dealing with patients with dual diagnoses?
Yeah, I mean, it boils down to one of the biggest issues being the risk of overdose, respiratory sedation and overdose and death. I mean, we're talking primarily about patients with opioid use disorder, but really anyone who's on more than one hypnosedative, and potentially anyone who's got also a chronic disease that reduces the respiratory threshold, is at risk of having a respiratory event and an overdose and potentially death. So think about it. How many drugs do we use to treat mental health? The key main players are the benzodiazepines and the antipsychotics. We know that use of benzodiazepines and antipsychotics doubles your potential risk of death if you've got a substance use disorder. And then you put on top of that the fact that we're treating patients with substance use disorder with drugs like methadone. Well, so then we have a combination of someone who's on antipsychotics, benzodiazepines, and methadone. It all starts to mount up what I call the hypnosedative load. And the higher the load, the closer to the cliff face you're driving, and you just don't know where it's going to end. You don't know when you're going to drive over the edge. Another kind of issue is the potential for interaction. So, if we're using tricyclic antidepressants to treat pain, for instance, I mean, that can affect, that has downstream side effects affecting the cardiovascular system and also potentially the risk of sedation. So again, if you've got someone with a precarious heart and you put them on tricyclics and you have a stimulant use disorder, which causes, cardiomyopathy, again, you've got a recipe for, unfortunately, death. So it's so important to understand why you're prescribing a medication, what are the potential interactions with that medication, and really, how do you manage the risk to the patient? Because yes, we all, no doctor. The vast majority of doctors do not want to kill their patients. But a lot of patients die as a result of drug interactions. So, what's going on in that space? It's basically, is our desire to care for the patient is it that outweighed by our understanding and concern for the potential interactions? Who knows? But it is my opinion, it is better to have a live patient who's still in pain and suffering than a dead patient.
Of course, that is true. And of course, psychiatric comorbidity is a massive topic. Today, we've talked about mood disorders, anxiety, psychosis, ADHD, medication interactions, personality disorders, and trauma, and how all of this in combination with dual diagnosis can significantly impact our patients' quality of life, their treatment course and their management course through their treatment for substance use disorder, and how all of these interlay upon each other. It's a complex lattice work, and it requires due care and rational prescribing and ongoing empathy and support for the patient. It's been a long episode of Cracking Addiction. Thank you for your time, and bye for now.